Hello and happy Teach Me Tuesday. Welcome back for another neonatal topic broken down into smaller bits for you. My name is Lisa. I am a clinical nurse educator and an experienced NICU nurse. And this week we are following in our blood gas theme, and we are going to talk about ventilator management based on neonatal blood gases. Last week, we reviewed normal neonatal blood gases, and as I have mentioned over the last few weeks, I am a nurse educator. I help NICU nurses start their nursing careers and continue and grow in them and to understand more about what's going on. I am not a provider. I am not a nurse practitioner. I do not write orders. But what I hope that you can gather from today is understanding the three kind of main ventilators we use, what the blood gas is telling you, and if you're on that ventilator, what you may anticipate for your orders. Because ventilator changes shouldn't be a guess. We should have an understanding of what's going on enough to know this is what I'm going to try next, and this is what I would anticipate happening. We're going to also do a brief touch on conventional ventilation, high frequency ventilation, oscillating ventilation, and jet. I also just want to remind you that some of these things that we're learning are ways that you could be using the R of S bar when you're talking to a provider to say, hey, should we, change the rate? Should we change the PIP? Should we change the amplitude, right? Or when they say, I'm going to change the amplitude, you understand why we're doing that so that most importantly, you can explain it to the families. So that's our goal today. So let's dive in. First, we're going to talk about the conventional ventilator and the basics of that, right? Probably anyone that works in a NICU, even at a level 2, you may have had a baby on a ventilator for an hour waiting for a transport team. This is the most common ventilator we're going to see. There are many types of them, as you see down below, and there are many modes of ventilation. So it is important to we're going to talk about the basics today. I do have from actually last June a complete Teach Me Tuesday talking about different ventilation modes and kind of what that it looks like on blood gases. And we talk about breaking down the blood gases based on that in short videos. So go back on my YouTube page and look through that and you can find them. There's going to be new versions coming out soon, but if you need that today, I want to direct you back there. But let's talk about the conventional ventilator. We see it used with respiratory distress syndrome. You're going to see it for babies with apnea, initial ventilation. This is often our first line of defense, especially in units that only have a conventional ventilator. We use it for post-op support for our babies going down for operations. So remember, our initial settings, our rate is going to be 20 to 60. Our PIP could be anywhere from 18 to 30, also may depend on your mode of ventilation. Your PEEP could be 5 to 8. Of course, I've seen that up to 10. These are, again, our most basic settings. Our I time can be 0.3 to 0.5, and your oxygen is going to adjust based on your SpO2. So the tidal volume is directly delivered by those set pressures and the frequency of the rate. Depending on your mode of ventilation, again, I work somewhere where we used assist control all the time. I work somewhere where we use volume guarantee all the time, and I work somewhere where we use SIMV all the time. There are many different modes, but depending on which one is set is going to determine how big that pressure is inside the breath, right? How much tidal volume you're getting. So depending on which mode you're on is how you're going to kind of adjust them. But it's really important to know that during the inspiratory to the expiratory time is where the gas is being exchanged. So that PIP over PEEP, the mean airway pressure, all of that is determining how long and how big of a breath the baby has to take in order to exchange those gases. And so the con of the kind of conventional ventilator is there's so many different modes, and kind of figuring out what exactly works best for the patient you're taking care of can be tricky. And that's why we rely heavily on our respiratory staff and our experienced providers to kind of help us decide, hey, what should we be trying next? So use them as your resources. The high frequency oscillating ventilator, to me, kind of always reminds me of home. It was a first high frequency ventilator I used, kind of once we couldn't use the conventional ventilator for whatever reason. Most likely it was PPHN. I saw it with hypoplastic lungs, baby with severe CO2 retention. I just kind of think of my first unit that I worked on because that's what we use, and so kind of that sound of like the that's going on reminds me of that. So just always wanted to say that. It is unique because high frequency oscillating ventilator is trying to minimize that lung injury by delivering those small tidal volumes at rapid rates, but has active exhalation. So that's what's happening. Like even if you kind of watch a water bubble kind of bubble bounce in your circuit, you will see this going in there, and it's like in and out, in and out. Right? It's like do 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 do. But based on the drum is the speed at which that's happening. So it can sound very fast or kind of slowed down, but the oscillator has such a unique sound. So it's pushing air in and pulling air out. So it has an active exhalation phase, which makes the high frequency oscillating ventilator, HFOV, the unique, right, and what's happening there. Our typical settings are the frequency, so that's your hertz on the ventilator. It's going to be 8 to 15. 1 hertz equals 60 breaths, so 15 times 60 is 900. That's how fast it could be going. That is also kind of telling you how long they have to exchange that gas, and actually lower settings can tell you that the baby is doing worse. So that's something to think about with your high frequency oscillating ventilator. The amplitude is the wiggle. That's the period of time that the CO2 has time to remove and get out into that active exhalation. The MAP is your primary driver of oxygenation, and your oxygen again goes with your SpO2 target. And we're really trying to decrease our barotrauma here. So that's what's going on there. Remember that the MAP is doing the oxygenation and the amplitude is doing the CO2 clearance. So that's so important on here. AMP, CO2, MAP, oxygenation. Did I say it clearly enough? So let's get to our jet. So our jet is the newest ventilator to me. Used it for 7 years, but newer to me. And so there are two out there now. They have the 204 now. So just those are just two different pictures. I see this primarily either used as a primary mode of ventilation on extremely low birth weight babies, or for those babies with PIE, pulmonary hypoplasia, or air leaks. Again, we are doing this rapid, small pulses of air directly into the airway. There is an amazing video, and if you follow me on social media, I will be sharing it from the jet company that shows kind of what's happening at the alveolar level, and it is mind-blowing. So I suggest you watch it. The thing about the jet is that this is the passive exhalation, and the jet kind of moves like this, like tick, 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 and then the little break in between, which is much shorter than how I'm exempling it here, is when the CO2 is coming out in that passive exhalation, in that brief break in between. The rate is 240 to 660. If you notice, those are divisibles of sixes, so it's divided by 60. The PIP is controlling your tidal volume. Your PEEP is your alveolar recruitment, how long the little alveoli are open. When I think of the Jet 2, I always really think of the alveoli, and so that really comes back to this idea of what's going on with the PEEP. Your servo is your pressure. Your servo pressure is usually like 1.2, 1.4, and that's been the hardest one for me to understand, and I really have relied on my respiratory therapy staff for that. But I think we just need to really remember that we have a low tidal volume, but sometimes we can make them stronger. Make that tidal stronger, if that makes sense. So this is gentle, precise, lung protective. We do often use this as a way to reduce our risk of IVH because we're not getting this big changes in our lungs, which can impede blood flow around the body, can cause rushing of blood. And with gentle ventilation, we can also prevent major swings in our CO2 often. And so you will see the jet used very often in small baby protocols, small baby units, etc. So those are the three modes of ventilation. If you go back to previous videos, I do go into this much more deep, but that was an overview, a 9-minute overview. Sorry. So let's get into our gases. So remember last week we talked about normal. So today we're going to go into kind of those abnormal gases and what you would anticipate your order changes would be. So we know if our pH is low and our CO2 is high, it's respiratory, right? Respiratory opposite. That's what Rome is. So in respiratory acidosis, such as a gas of 71868 with a bicarb of 22, and a compensated gas or partially compensated, where we're getting our pH closer to normal at 7.32, our CO2 is still an outlier at 65, and our bicarb has now risen to try to help up to 30. Those are both respiratory acidosis gases. So our goal is to blow off the CO2. So what are we going to do? On a conventional ventilator, we would increase our rate, so we're breathing faster, or we would increase our PIP to make that breath bigger to have a longer time to exchange the gases. On the oscillator, we talked about how the amplitude is the driver of our CO2, so we would increase that, or we would decrease our hertz. As I mentioned, that hertz, when it's shorter, a lower number, it creates a longer time, almost like a bigger surface area for the gases to be exchanged. And so in that setting, with a lower hertz, you're going to get your CO2 blown off faster. On the jet, you can increase the PIP, your servo, or backup rate if you're on that. So your servo pressure could change, your PIP could change, or if you're, we call them psi breaths or kind of those extra breaths, you could change your rate on that. So be mindful of how we're correcting, but these are what you would anticipate for next steps if you are a baby, if you are a nurse taking care of a baby with respiratory acidosis. I know you're not a baby. I've got that under control. So let's talk about respiratory alkalosis. So here, again, the pH and the CO2 are opposite each other, but the pH is high. So that's how we know it's respiratory alkalosis. A gas example would be 751 with a CO2 of 26 and a bicarb of 22. If we're compensated, we're moving closer to normal. So our 745 is our pH. Our bicarb has dropped to compensate for that high CO2. So we need to get our CO2s up. So what should we do? Conventional ventilator, we're going to drop our rate, or we would consider dropping our PIP. Our high frequency oscillator, opposites, right? So we're going to decrease our amplitude or increase our hertz. And then our jet, we could go with our PIP jet on the jet, the servo, or the backup rate. I have also seen some changes, with your PEEP. So depending on how long you want them to have an opportunity to exchange those gases, I've seen the PEEP change on the jet. So that's something that could happen. We could add that as one of our factors here. But again, if a goal is to get your CO2 to rise, right? That's what we have here. We went forward. So we want our CO2 to rise. We've got that idea going for us. So now we are on metabolic acidosis. So you can see here, we've got a low pH and a low bicarb. So those are equal. So when they are equal, we know it's metabolic. And with a low pH of 721 outside of normal, we know that this is metabolic acidosis. As we talked about last week, metabolic acidosis is often a product of something else going on, such as sepsis or NEC. So we would want to support perfusion going on here, avoid excessive ventilation, address the root cause, such as sepsis, hypoxia, or shock. When we're able to address that root cause, we're probably going to fix the gas, right? So depending on what's going on there, bicarb, we have mentioned here, I think we're actually using it less than we used to, but it is an option that we could consider in this situation. With metabolic acidosis also can correct as other things are being fixed. So that's something to think about too, is to just kind of avoid what's going on with excessive ventilation and what you would consider for that. So we don't want the CO2 to go too low. We know that. So that's another key point here. But really keep in mind, if you're on your conventional ventilator, you would be mindful of what we're doing with our rate. We would be mindful of what we're doing with our PIP. On our oscillator, we would like to avoid excessive amplitude or a very low hertz. Again, the low hertz is a sign that you're increasing your support as your hertz goes down. It's like an oppositor that we don't always think about. And then the same thing with your jet. Your jet, PIP and PEEP, just like everything else, are going to deal with your MAP. So you need to make sure that you know what's going on with your MAP to avoid that overventilation. So we come to metabolic alkalosis. So you have a high pH, right? 750. You've got a high bicarb, so they're both moving in the same direction, metabolic equal. And our CO2 is 46. Maybe we're trying to help compensate here slowly. It's tricky, metabolic alkalosis. Again, we need to think about, is there something going on, such as what is our fluid balance? What are our diuretics? What's going on with the volume within the baby? A vent change may not be our first line of defense for metabolic alkalosis, but you would want to be monitoring these things. So Could we decrease our rate? Could we be dealing with our PIPs so that we could maybe increase our CO2 to help with compensation? That's what's going to happen here in this mode on conventional ventilator. On the high frequency, we want to make sure that as our CO2 is rising, we're watching what our hertz and our amplitude are doing. And on the jet, we want to ensure appropriate PIP from our jet and our servo. We don't want to wean anything too quickly, especially if there's an underlying cause such as diuretics or prolonged vomiting. So this is just something we want to keep in mind. I do think that the acidotic gases make us more alarmed, but every gas that's outside of the normal needs to be treated and approached equally. With hypoxemia, which I do think is interesting, just to kind of touch on, is when we can watch our PaO2. So if you have an arterial gas or you're watching trends from other gases, is to really make sure that the amount of oxygen that your infant is receiving matches what their PaO2 is doing. So if you're in this first gas with a gas of 736, 48, and PaO2 of 35, but you're on 70%, you would assume your PaO2 would be higher. So if we want to get a higher PaO2, so we want our baby to have more oxygen circulating in their blood, our lungs, we want to do that by improving oxygenation. On the conventional vent, we would probably change our PIP and our PEEP so we have more opportunity for that exchange. On the high frequency, again, our MAP is our primary driver of our oxygenation, so we would change that. And then our jet, we would change our MAP or our PEEP. So we also need to be mindful that we don't get into another place, a hyperoxia, which we're going to talk about in the next slide, but we just need to use our PEEP and our MAP to have more opportunity for gas exchange and without the alveoli collapsing so that it can have that exchange. Remember PEEP. I could probably have mentioned this at the beginning, but the idea that PEEP is positive ended expiratory pressure, right? So we're keeping those little alveoli open at the end so that there's time for this gas exchange. And so that's really what I think about is when I need my gases to exchange, what is with hyperoxia, right? You see these high levels going on. We have our PaO2 is at 150, 105. We have high oxygen requirements at 50 and 60%. They're not like scorching high, but in general, we want to make sure that our SpO2 and our PaO2 are kind of matching each other. And if they're not, if you're having to turn it up because you're watching your SpO2, you also needed to be thinking about something like, is something going on with the heart? It could be something from PPHN all the way to a cardiac defect, especially depending on where you have your SpO2 monitor. This might be an opportunity where you're going to do pre and post ductal. We need to avoid this oxygen toxicity, especially in the setting where our gas looks pretty good. What are some things that we could be doing? On the conventional ventilator, we could decrease our PEEP. On the high frequency, we could change our MAP. And on the jet, we could decrease our PEEP. We have not been talking about weaning the jet a lot. The jet weaning often comes from the x-ray. And often babies are put on the jet because of overexpansion in the setting of poor gases or poor oxygenation in really high settings on a conventional ventilator. And so we put them on the jet to start to kind of decrease this overinflation from pip, peep, right? Those breaths and on the conventional ventilator. So the jet rate, yes, you could decrease that in the setting of some of these respiratory alkalosis or this hyperoxia, but it's not often our first choice. And we often are also looking at the wiggle to make sure that the wiggle kind of matches the baby, and that's where our servo pressures end up. So as your baby gets more compliance, you might be changing your servo pressures, which could be reflected in a hyperoxia situation. But just something I wanted to mention, because you may notice we don't talk about that rate very often when we're talking about our jet. So in relation to what's going on, I also really, and I have recently learned that respiratory therapy and respiratory therapists are often a American, you know, Canadian, some European countries thing, but they don't have RTs everywhere, which is mind blowing. But we know in the setting of too much oxygen, we are putting the baby at risk, especially for ROB, but BPD. But have your RT come over and help you decide what you should maybe do if you're experiencing this. This is a summary table. I've put in all of the things that we've talked about so far in here. Snip it, pause me, take a picture on your phone, carry it around with you. If you reach out to me, I also have this as a printable resource available for you. So email me or message me and I will get it to you. As long as I have your email address, I can give it to you. So let me know. This is a summary table. Everything we've gone over, take a picture. It's beautiful. So what can we tell our parents? What I wanted to give you today was a script. And this is again something you could take a picture of, take a screenshot of. What could you be doing, especially have you had a parent walk in and you still have two ventilators in there because we're trying to decide if we want to go on high frequency or the jet or stay on conventional? Maybe try, have you seen things where we're trying higher rates on conventional ventilators? So that could be overwhelming. Can you imagine as a parent walking in and seeing multiple ventilators in your patient's room? So I say things like your baby will be placed on one of several types of ventilators depending on their needs. Some ventilators deliver gentle, fast breaths, while others do more that traditional in and out like you and I do. Providers choose this based on lung condition, oxygen and CO2 levels, your x-ray, how young your baby is, what we can be doing with the fluids, if they've had surfactant. There are a lot of factors that go in. Though they all look and sound different, they have the same goal: help your baby breathe effectively and safely. If you're unsure of what's happening in here, ask us and we can help. It's reassuring. It's also reassuring to say, hey, if you're talking to them on the phone, your baby is on the conventional ventilator and we may need to bring in a ventilator called the jet. It doesn't mean that your baby is on a last piece of equipment that we've ever had. It just means this is what your baby needs right now to help them. And we have the resource and this is what we're going to use. I think sometimes when we go on a different ventilator, we see as a step back when maybe it's just an equal movement, but we need to achieve a different goal. And so that's what I like to impress upon them. So that was a lot. We've pushed past 20 minutes. I'm sorry. I tried to speak faster, but I hope that this helped to see that blood gases act as your compass. They guide you through your current status. The ventilator is a tool to get you to the next thing. Looking at your map on your high frequency oscillator for hypoxemia, lowering your rate on your conventional ventilator, knowing what your jet is doing with the passive exhalation, that the jet really works to get to the alveoli level, and that's why you're going to see a PEEP going on there, recognizing that our conventional ventilator may need higher pressures while your oscillator has active exhalation with the piston, which you can see in there in the little drum. You need extra high MAP often to stabilize your alveoli. On the jet, your MAP may actually be lower than it was on a conventional ventilator because it's maintaining the airway pressure and reducing the risk of barotrauma. And that decreasing the risk of barotrauma may also help with brain protection. All of these little patterns build confidence when we respond with intention. And when we think about what could the next step be, it helps us be better, more prepared nurses. Thank you for joining me today, and I will see you next week for an all-new Teach Me Tuesday.